right, so chapter 33, obstetrics and neonatal care. Most deliveries occur in hospital. However, a great deal of deliveries happen at home or in the car. Occasionally, the pregnant woman is unable to get to the hospital, or simply she chooses not to go to the hospital. Either way, when you get there, you must decide whether to assist the delivery on scene or to transport the patient to the hospital. If you visualize and you're seeing crowning, which is the baby's head at the opening of the vagina, then it's safe to say that you're going to be setting up a delivery area and you're going to be delivering that infant at home. If you visualize and you're not seeing any crowning, mom doesn't feel the need to push, then go ahead and get her in the ambulance and get her to the hospital. So quick review for anatomy and physiology. The ovaries are glands. There's one on each side of the uterus, and each ovary contains thousands of follicles. Each follicle contains an egg, and ovulation is when the ovary releases the egg into the fallopian tube. It happens approximately 2 weeks prior to menstruation. And within the fallopian tube is generally where fertilization happens. Occasionally it happens in the uterus, but more often than not, it actually happens within the fallopian tube. So the egg is released from the ovary, starts traveling through the fallopian tube where it's met with a sperm, and that's where fertilization happens. The fallopian tube connects the uterus to the ovary, so it's like a nice little bridge there for that embryo, or the egg, which will then become an embryo once it's fertilized. The fertilized egg travels into the uterus, and that's where it turns into an embryo, and then eventually turns into a fetus, and what we think of as a baby. The uterus is a muscular organ that encloses and protects the developing fetus, produces contractions during labor, and these contractions help push the fetus through the birth canal. So the uterus can provide up to 600 pounds of pressure per square inch. So it can literally do all of the work all on its own to push the baby through the birth canal. So if mom's in a bad situation where maybe she's unconscious, or if she's in a coma, that baby is still going to be able to come out without mom having to do the work of pushing. The birth canal is made up of the vagina and the lower third of the uterus called the cervix. So the cervix is quite thick, or tall, I guess. You can think of it as tall. And as the baby's head comes down, it puts pressure on it and it gets shorter, and it also thins out. Eventually, after labor has progressed enough, it's going to be very thin and very open to allow the baby to pass through the opening. So the vagina is the outermost cavity of the reproductive system. It forms the lower part of the birth canal. It completes the passageway from the uterus to the outside world. Breasts, they produce milk that's carried through small ducts to the nipple to provide nourishment to the newborn once it's born. Kind of at the end of this, when the baby is born, there's a possibility of hemorrhage. Now, if mom is hemorrhaging and you're having a difficult time controlling it, you can encourage her to nurse or breastfeed the infant. During breastfeeding, mom's body will produce hormones that will cause the uterus to contract, which can help in controlling bleeding because it's causing the uterus to contract. The placenta attaches to the uterine wall and provides nourishment to the fetus. This is kind of the doorway, so it connects mom and baby. The placenta is the lifeline for the baby. It keeps the circulation of the woman and the fetus separate, but allows substances to pass between them. So anything ingested by a pregnant woman has the potential to affect the fetus. There's a great deal of blood flow that goes to the placenta and back. So you've got, anything that goes into mom's system has the potential to go through the placenta and into the baby or the fetus. The umbilical cord connects the woman and the fetus through the placenta. So when it comes to oxygenated and deoxygenated, it gets a little tricky here because you have mom's system and then you also have baby's system. So if you think of it as who owns the umbilical cord? Does mom own the umbilical cord? No. Does baby own the umbilical cord? Yes. So we are going to look at oxygenated and deoxygenated from the baby's perspective. So veins carry blood to the heart. So who owns that umbilical cord? The baby. So the umbilical veins are going towards the baby. Now, who has the oxygen? Does mom have the oxygen or does the baby have the oxygen? Mom has the oxygen. So that vein that's going to the heart is going to be carrying oxygen from mom. So it's a vein that carries oxygen towards the heart. Now, umbilical arteries, again, umbilical or the umbilical cord belongs to the baby. And so the baby's arteries go away from the heart. So the umbilical arteries are going to be carrying deoxygenated blood back towards mom, so away from the heart. It can get a little bit a little wonky because it's different than what you kind of expect. But if you break it down and you think of it as who owns the umbilical cord, the baby. So veins go towards the heart and arteries go away from the heart of the baby. And who has the oxygen? Mom has the oxygen. So when it's going from mom to the baby, it's going to be oxygenated. And when it goes from the baby to the mom or the placenta, it's going to be deoxygenated. So the fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. It contains 500 to 1,000 milliliters or 1 liter of amniotic fluid. Now, this varies from pregnancy to pregnancy or woman to woman. It's not always going to be within that range. Sometimes there's more, sometimes there's less. There can be complications if there's too much, and there can be complications if there's not enough. But this is kind of a vague general volume amount. The fluid helps insulate and protect the fetus. So when mom has something happen to her, that fluid protects the fetus. During pregnancy, other body systems undergo changes. You can see in this little GIF here that everything gets displaced. Everything gets displaced. The entire body goes through this amazing change. So you have respiratory changes, you have cardiovascular changes, and you have musculoskeletal changes. And we'll talk about each one of these. For the most part, your respiratory system, you have a significantly lesser tidal volume. You're not going to be able to take those big, deep breaths because if you look here, the uterus is rising and it's pressing all of those abdominal organs up into the diaphragm. The diaphragm has nowhere to go, so the diaphragm moves up. So there's less room for those lungs to actually expand. Cardiovascular changes, again, a pregnant mom is circulating a significantly greater amount of blood because mom's body is starting to prepare for childbirth. And with childbirth, there's generally a great deal of blood loss. So mom's actually producing more blood. On top of that, she's now circulating, she's circulating this entirely newly large organ and providing nourishment to a growing fetus. And then musculoskeletal changes. There's significant hormones that are produced that significantly change things. The hormone specifically that I'm talking about is called relaxin, which is so easy to remember because it's called relaxin. And what does it do? It relaxes everything to help facilitate childbirth. So it helps relax the pelvis to allow the infant to pass through the birth canal. Unfortunately, it doesn't just relax the pelvis, it relaxes everything. So pregnant women are much more susceptible to having musculoskeletal injuries just simply because they're not held together as well as they were pre-pregnancy. So kind of what I already said, hormone levels increase to support fetal development and prepare the body for childbirth. Pregnant women are at an increased risk for complications from trauma, bleeding, and some medical conditions. The uterus is shifted from its normal position. Again, it pushes all of those abdominal organs up into the diaphragm, which creates some issues in your interthoracic area because there's not as much space as there normally is. Rapid uterine growth occurs during the second trimester, and as the uterus grows, it pushes up on the diaphragm and displaces it. Respiratory capacity changes with increased respiratory rates and decreased minute volume. Blood volume and speed of clotting increase, again, to prepare mom to be able to survive childbirth. And cardiac output is increased. Again, the heart is having to work that much harder to circulate all that extra blood and then again to circulate and perfuse this infant, to perfuse blood to this infant. In the third trimester, there's an increased risk of vomiting and potential aspiration following trauma. Again, everything's pushed up, everything's kind of like under pressure. So, mom's more likely to vomit anyway. And then, you you put that in combination with trauma, and aspiration is just much more likely to happen than with an unpregnant woman. Changes in the cardiovascular system and increased demands of supporting the fetus increase the workload of the heart. So this is kind of reiterating what I've already said. Weight gain during pregnancy is normal. So they say somewhere in the 25-pound range. However, every single woman is different. And some women gain 20 pounds, some women gain 70 pounds. So long as their doctor is not concerned, there's not really going to be any difference in what we're going to do. Unfortunately, it does create some challenges. So it makes the heart have to work a little bit harder. That increased weight is also taking effect on the musculoskeletal system, which is already kind of behind the eight ball because the joints are looser because of that relaxin that mom's body is producing to prepare for childbirth. On top of that, mom is very unbalanced. So now she has this significant amount of weight at her front. So she's having to work really hard to keep her balance because her center of gravity is all out of whack. Nothing is where it's supposed to be. She's changing by the day with significantly rapid growth. So now here we have an increased amount of relaxin. So all of her ligaments and joints, everything's really loose. So on top of that, she's heavier than she's normally. And this is a rapid change. This isn't something that's happened over a period of years. This has happened over a period of weeks. So extremely rapid growth rate. Her size is changing. Her center of gravity is changing. She's going to fall. She's a lot more likely to fall. And because of all of those other changes, she's also a lot more likely to actually become injured when she does fall. Complications. Most pregnant women are healthy. Some pregnant women are not. Some pregnant women are ill when they become pregnant, and some women become ill during pregnancy. Now, there's a couple different things that we can kind of expect. They're somewhat normal, and we'll talk about those. But diabetes is a good example. So some women are diabetic before they become pregnant. And then other women develop what's called gestational diabetes, where they become a-diabetic during pregnancy. And then once pregnancy is over, they deliver the baby. They're no longer a diabetic. So, there can be issues that or illnesses or chronic diseases that happened before pregnancy, and there can be ones that start with pregnancy or are caused by pregnancy. Anytime mom needs oxygen, baby's going to be needing oxygen. Pretty much with most life-saving medications or medications including oxygen that are needed acute care are going to be beneficial to the infant. So like for instance, epinephrine. If mom starts having an allergic reaction, yeah, we're not really sure exactly what's going to happen to the infant with that epinephrine, but what's going to happen to mom if we don't give her epinephrine? She's going to stop breathing it? No. So there's a lot of things that we can do, a lot of interventions that there's not a lot of evidence to tell us what's going to happen to the baby, but as long as we're taking care of mom and we're not purposefully doing anything to harm mom, which we shouldn't be doing anyway, it's going to help baby in the long run. So here's this diabetes that I was talking about. So gestational diabetes develops during pregnancy in many women who have not had it previously. Generally resolves after delivery, and the treatment's the same for any other patient with diabetes. You've got mom who's running low, give her oral glucose. Mom that's high, she's could be able to control it with like oral medications, or she may need to have insulin injections. It just kind of depends on the severity of her gestational diabetes, what the treatment is, and that's not up to you, that's up to her doctor. Now, hypertensive disorders. This is another one that can be quite common. Unfortunately, it is a little bit more scary. So preeclampsia. Preeclampsia is a common complication. What that is, it is pregnancy-induced hypertension. Can develop after the 20th week of gestation. Signs and symptoms include severe hypertension, severe or persistent headache, visual abnormalities, swelling in the hands and feet, and anxiety. Those are all common signs and symptoms of high blood pressure. So anytime you've got a patient who has those symptoms, you can kind of expect high blood pressure. Pregnant women are no different. It's just that pregnant women are more likely to have these things because preeclampsia is relatively common. Now, when preeclampsia progresses and it goes untreated, it can evolve into eclampsia. Now, eclampsia is a big deal. It's characterized by seizures that are a result of hypertension. Now, we cannot be having seizures. This is one of those reasons that women will have C-sections before the baby is done cooking, because it can be life-threatening when mom starts having seizures regularly. If of course, if it's not able to be treated. If you have a pregnant woman who starts having a seizure, you need to treat the seizures. Have the patient lie on her left side. This is the one difference from the average Joe having a seizure versus pregnant mom having a seizure. So treatment's going to be the same for both Joe and mom, with the exception of you're going to put mom on her left side. What this does is it helps when you have a pregnant woman and you lay her flat on her back, the weight of the fetus is actually pushing down on her aorta and her vena cava. So it causes blood pressure changes. Now, if you lay her on her side, you're not putting pressure on those major blood vessels. So that's why we place pregnant women on their side. Now, left side is preferable to right side, but if she has, like, say, a left hip fracture, you can definitely put her on her right side. It's not a left side only. It's more or less just put her on her side. And again, just like the average Joe, maintain patient airway, give high flow too. If there's a vomiting, suction the airway, keep her airway clear, and get her to the hospital so they can get, further treatment. When you're transporting the patient just on the left side, it can also prevent supine hypotensive syndrome, which is caused by the compression of the descending aorta and the inferior vena cava by the pregnant uterus when the patient is supine. Just like what I said before, lying them on their side reduces the weight, compressing those vital blood passages. So, ectopic pregnancy. An ectopic pregnancy can be life-threatening if it ruptures. So, this is not something that you mess around with. An ectopic pregnancy is simply a fertilized egg or embryo that has implanted and started to develop somewhere outside of the uterus. Not always within the fallopian tubes, but most commonly within the fallopian tubes. You can see here in the picture that there's not much space there. The fallopian tubes are very small. So that fertilized egg is not going to get very far before it actually ruptures. If it ruptures, it can be life-threatening for the mother. With ectopic pregnancies, when they're present, there's going to be a great deal of pain, generally on one side or the other, because it's very close to the ovary, so it's not going to be symmetrical in the uterus. It's going to be in one of the fallopian tubes. So that great deal of pressure causes quite a bit of pain. But hopefully you'll catch it before it ruptures, so that the woman is not going to hemorrhage. Leading cause of maternal death in the first trimester is internal hemorrhage following the rupture of an ectopic pregnancy. Like I said, these are not something that you mess around with. This is a big, scary problem. Consider the possibility in a woman who has missed a period and complains of sudden severe pain in the lower abdomen. Like I said, it's more likely than not going to be on one side or the other. Hemorrhage from the vagina that occurs before labor begins can be quite serious. It can be a sign of spontaneous abortion or miscarriage. So spontaneous abortion is just the medical term for a miscarriage. There are also two other reasons that mom can have bleeding before labor. One of which is abruptio placenta, which is where the placenta prematurely separates off the wall of the uterus. Now, again, remember the placenta is the baby's lifeline. So this is where all of the blood moves. This is where oxygen exchanges, waste removal, nutrition, everything else. So basically all of mom's blood flow comes to that placenta, and all of baby's blood flow comes to that placenta, and they meet. So there's open blood vessels in that area. Now, if mom gets in a car accident and is hit on her belly, it can cause that placenta to start kind of tearing off the wall. Now, when it starts separating, there's open blood flow that starts seeping out. These are arteries that are now exposed. So that blood will accumulate outside of the amniotic sac and will, exit through the cervix into the vagina. It can be a big deal. So definitely a reason to go to the hospital. Now, the other one is placenta previa, and it's when the placenta actually forms at the lowest portion of the uterus, and it actually covers the cervix. Now, remember, everywhere where that placenta is adhering to the uterus, there is open blood flow. So if it adheres over an opening where the cervix is, there's nothing that's that those blood vessels are open. So if the cervix starts to dilate for any reason, you're going to have open blood flow right there over the cervix, which is going to cause vaginal bleeding. Placenta previa can be totally fine, and mom can be totally fine her entire pregnancy. If her cervix starts to dilate and she starts hemorrhaging, it's a very, very big problem and can be it can be life-threatening quite quickly. So here you have a visual. So the first one on the left, you see placenta abruptio. So you can see that the placenta is pulling off of the wall of the uterus. On the one on the right, you can see where the placenta is over the cervix. Now, if you think about childbirth, can the baby come out with that placenta in the way? No. But with the baby pushing down on it, the cervix is going to start dilating. If the cervix dilates, you're going to have blood loss. If it dilates enough, um, the, my my doctor actually described it as being the equivalent of someone cutting their carotid artery. That's how quickly mom will bleed out. I was advised that this is the type of medical emergency that doctors will not scrub in for surgery. It will be an emergency C-section. Doctors won't be scrubbing in, and they may not have time for any anesthetic. And it's because they have to move that quickly to save mom and baby. So if you have a patient who reports placenta previa and they have a great deal of bleeding, this is like, don't waste any time. Get them to the emergency room, code 3, lights and sirens, get them in the door, let them know immediately that you have a hemorrhage on a pregnant woman who has placenta previa. This is a life-threatening emergency. So abortion, again, abortion is a clinical term, does not necessarily mean elective. Okay, so abortion refers to the passage of a fetus and placenta before 20 weeks. It can be spontaneous or induced. So induced would be like the elective procedure, the controversial, what most people think of as an abortion. Most serious complications are bleeding and infection. Treat for shock, transport promptly. Abuse. Pregnant women have an increased chance of being victims of domestic violence and abuse. Abuse increases the chance of spontaneous abortion, premature delivery, and low birth weight. Kind of overall, if mom's not the healthiest because of one reason or another, she's more likely to have spontaneous abortion, premature delivery, and low birth weight. That includes emotional issues. So if she's emotionally abused, she's not going to be as healthy as someone without that constant abuse. It takes toll on the entire body, not just mental. The woman's at risk from bleeding, infection, and uterine rupture with physical abuse. Pay attention to the environment for any signs of abuse, and talk to the patient in a private area away from potential abuser if possible. Obviously, you don't want to ask, Tina Turner about her abuse in front of Ike. You just use discretion, take her to the ambulance, ask those questions in the ambulance. Substance abuse, it affects addiction on the fetus. Effects of addiction on the fetus include prematurity, low birth weight, severe respiratory distress, and even death. If mom is abusing or using substances, that's one of those things that passes through the placenta and affects the fetus. Fetal alcohol syndrome is another one. So when mom is an alcoholic and continues to drink throughout her pregnancy, the baby is going to be born addicted to alcohol. For a woman who is using, narcotics or heroin or, she's a drug user, the baby is going to be born being addicted. So anytime you have someone who is that suddenly stops using or suddenly stops drinking, they're going to go through withdrawal. Once the baby is born, the baby is not getting that constant flow of these, uppers or downers. So the baby is going to go through withdrawal, which can be quite detrimental. It can cause seizures. It can cause, all sorts of issues, um, including prematurity, low birth weight, severe respiratory distress, and then, of course, death. Pay attention to your safety. Anytime you're considering delivering a baby, know that there's going to be a lot of fluid involved. So that's a lot of bodily fluids, and you need to protect yourself. You should be protecting yourself anyway. You just need to be hyper vigilant if you suspect that mom is a user. Look for clues that you're dealing with an addicted parent. Clues like, do they have meth mouth? Do they look underweight? Are there track marks? Overall, is the home or the place that the patient is it clean? Is it, is there paraphernalia? Kind of use your best judgment when it comes to that. The newborn will probably need immediate resuscitation. It's pretty much safe to say the moment you find out that you have an addicted mother, you should probably be calling for assistance, especially if you're going to be delivering a baby right then and there. That baby's more likely than not going to need resuscitation, and you don't want to be dealing with two patients when one of them needs resuscitation. You need to have a backup unit on their way so they can deal with the infant and you can deal with the mother. Special considerations for trauma and pregnancy. With a trauma call involving a pregnant woman, you have two patients. You have the woman and the unborn fetus. Anything that you're doing for mom to help mom is going to be helping the baby as well. So if mom needs compressions, then baby's going to be benefiting from mom's compressions. If mom needs to be cardioverted, or if mom needs to be defibrillated, baby's going to benefit from that. Pregnant women also have an increased risk of falling. So just be mindful that, she may have fallen just because she's pregnant, not necessarily because she tripped over something or, maybe had a loss of consciousness. Obviously, you're going to ask those questions to try and investigate and find out what actually happened. But just be mindful that it's not uncommon for pregnant women to be falling. Pregnant women have an increased amount of overall total blood volume and a 20% increase in heart rate. So the big thing to take away from this is that they can experience a significant amount of blood loss before you start seeing signs of shock. Your body is producing all of this extra blood to prepare for a blood loss. So when blood loss happens, they're able to compensate. The uterus is vulnerable to penetrating trauma and to blunt injuries. The uterus can rupture. So anytime you have a blunt injury to a pregnant uterus, the uterus is nice and thick when it's not pregnant. When it is pregnant, the wall is very thin and it's under some pressure. So if you rupture it, obviously it's going to cause some serious problems for mom, but it's also has the potential to create some pretty serious problems for baby as well. In a motor vehicle crash, severe hemorrhage may occur from injuries to the pregnant uterus. Again, remember placenta abruptio is a possibility. Trauma is one of the leading causes of abruptio placenta because it causes the placenta to tear away from the uterus. Common symptoms include vaginal bleeding and severe abdominal pain. Improper positioning of the seatbelt can also cause the pregnant woman to have injuries as well as the fetus. Having been pregnant a couple times, seatbelts can be quite difficult to get comfortable, but they need to be worn across the iliac crest, low on the lap, not above the pregnant belly, which is what some moms want to do when they're pregnant. Cardiac arrest. Again, like I said, if mom is in cardiac arrest and she needs to be defibrillated, baby is going to benefit from that also. So don't let her big belly deter you from doing what needs to be done during a cardiac arrest. Your focus is going to be the same with pregnant mom as it will be for any other patient. Provide CPR, provide transport. Compressions may need to be done just a little bit higher because remember, everything has been pushed up. So her heart is actually a little bit higher in her chest. Um, so, just kind of move up just a smidge when you're doing your compressions. Your focus is on the assessment and management of the woman. Again, anything that you do that benefits the woman is also going to benefit the fetus. I can't stress that enough. Follow these guidelines when treating a pregnant trauma patient. So maintain an open airway, provide high flow O2, ensure adequate ventilation, assess circulation, and transport the patient on her left side. All of that is stuff that you're going to be doing with any trauma patient, with the exception of the left side. So pretty much the only thing you're going to do differently is transport her on her left side, if at all possible. Now, if you have to put her on a spine board, you can, do a full C-spine and then use a towel underneath her right side to kind of tilt the whole backboard towards her left. To take the pressure off of the blood vessels. So cultural value considerations. Cultural sensitivity, super important. Some cultures do things differently. And that's the benefit of living in a world where nobody has to do things a specific way. Each culture gets to do them their own way. Things change with how they plan for childbirth. Things change with how they deal with pregnancy, and how they expect to deliver. So in some cultures, most cultures actually, it's done at home. It's not done in a hospital, where here in the US, most babies are born at the hospital. So things like that are going to be different. Now, just because somebody has a different idea of how they want to do things doesn't mean that they're doing it wrong or that they are refusing to get medical treatment. It's just that they never even considered needing to have medical treatment or to have prenatal care. It may not be part of their culture and it may not be part of their normal practice. So just kind of, be mindful and be respectful, and also try to educate when it comes to emergencies. If there is an emergency and they need to go to the hospital, you may have to do some education to get them to agree to go to the hospital, when it's in the best interest of both mom and baby. Some cultures may not permit a male healthcare provider to assess or examine a female patient. Respect the differences, on a request from the patient as best as you can. Request another unit that has a female EMT. If there aren't any available, see if you can get a female law enforcement officer to help you. Most law enforcement officers are trained in basic medical care and needs, basic first aid, those kind of things. But they can help you out when it comes to needing to visualize, which can be very important in determining whether the patient needs to deliver at home or if you have time to get them to the hospital. Also, it's really important to visualize for complications like having a prolapsed cord, or maybe limb presentation where the baby's arm comes out first. Teenage pregnancy. So in the United States, we have one of the highest teenage pregnancy rates. It's kind of one of my soapboxes here. I think a big part of it is because we are not educating our young people on how to protect themselves from pregnancy. It's quite unfortunate. Pregnant teenagers may not know that they're pregnant, or they may be in denial. So they think, I only had sex once. There's no way I could be pregnant. And so they are in complete denial. And some of these people, if their body shape and structure is of a certain way, they may not be showing. They may not know that they're pregnant until they go into labor. When that happens, it's kind of bizarre, but it happens. It can happen. Anytime you've got a pregnant teenager, you need to respect their privacy. This is one of those things that is, I don't want to say controversial, but it takes a little bit of finesse to kind of deal with and manage. If the child has not advised their parents that they are pregnant, it's not your job to advise the parent. If the child chooses not to tell their parents, then their parents don't have a right to that knowledge. So if 16-year-old tells you that she's sexually active, she's, 6 months late on her period, and she's now having, you know, some sort of complication with her pregnancy. When the parents ask what you think is going on, all you can really say is that your daughter is having a medical emergency. There's something going on within her body, and she needs to get to a hospital. You cannot say specifically that it's because she's pregnant, because that is part of the child's protected health information. It's a violation of HIPAA. Even though they are a minor, you don't get to tell the parents that she's pregnant. So respect her privacy. Definitely get that information. Find out if her parents know, so you don't end up causing some problems. Patient assessment. So childbirth is seldom unexpected. Like I said, there can be times when it's unexpected, but more likely than not, there's going to be occasions, it's more likely that it's going to be an emergency that arises during expected childbirth than when childbirth is actually a surprise or an emergency. In safety, take standard precautions. Like I said before, childbirth is messy. There's a lot of bodily fluids. So make sure that you have fluid impermeable gown, you've got goggles, you've got a mask, you've got everything that you have available. You don't need a hazmat suit, of course, that would be excessive, but pretty much everything else. Gloves and eye and face protection are a minimum if delivery's already begun or is complete. So even if the baby's already born, you still need to gown up because things are still going to be yucky. If time allows, you should put a gown on. Consider calling for additional resources, because in the event that you get a baby who is in need of resuscitation, it's not something that you're going to be able to handle on your own with just you and your partner. Mechanism of injury and nature of illness. So you'll encounter pregnant patients who are not in labor. So it's important to determine the mechanism of injury or nature of illness. Don't develop tunnel vision during a call. So just because she's super pregnant doesn't mean she's having an obstetric emergency. She may be having, a traumatic injury where she hurt her knee. She may be having a diabetic emergency or a cardiovascular emergency that's not necessarily related to her pregnancy. What if she has an allergic reaction to a bee sting? That's not a pregnancy problem. That's just a problem that happens to coincide with her pregnancy. Find out what's going on. Don't just focus on the belly. Form your general impression whether the patient is in active labor or you have time to assess and address other possible life threats. Perform a rapid exam. So head to toe, you're looking for anything that's going to kill her quickly. Airway and breathing, obviously, life-threatening conditions with the woman's airway and breathing are usually not an issue during birth. Motor vehicle crashes, assault, or medical condition may cause a life threat. Be mindful, look for them when you find them, treat them. Assess the airway and breathing to ensure they're adequate, just like any other patient. Circulation, blood loss after delivery is expected, but significant bleeding is not expected. Assess for and treat life-threatening bleeding. If you have life-threatening bleeding, you can do what's called a fundal massage. So I believe we'll cover that at the end of this lecture here. But it's basically pressure in a kneading motion on mom's belly after the baby is born to try to help put pressure on that uterus to help control the bleeding. Again, like I said before, you can also encourage mom to breastfeed, which will help the uterus contract to help control a hemorrhage that's post-delivery. Your transport decision, if delivery is imminent, prepare for delivery at the scene. If delivery is not imminent, then prepare the patient for transport to the hospital. Provide rapid transport for pregnant patients who have significant bleeding and pain if they're hypertensive, having a seizure, or have an altered mental status. Get a thorough obstetric history in addition to a regular medical history, because again, just because they're pregnant doesn't mean that they don't have a medical history. So get both. Get your good normal medical history plus your obstetrics medical history. So in that, you need to find out her expected due date, any complications that she is aware of. So like, for instance, placenta previa, that's a big deal. You need to know about that. If she has been receiving prenatal care, and a complete medical history. Like I said, all of the stuff that's not obstetric related. Determining the due date, frequency of contractions, a history of previous pregnancies and deliveries, the possibility of multiples, and if she's taken any drugs or medications. Those are all really important. So somebody who has never given birth before is going to take a lot longer to progress through labor than someone who has had maybe 5 babies. The woman who's had 5 babies, you can expect it to go a little faster, quite a bit faster in most cases. If her water has already broken, you need to ask what color it was. Was it clear? Was it green? Was it like a brownish gray color? Did it have a foul odor to it? Those are all really important questions. The hospital is going to ask you those questions, so be prepared for them. If it is greenish and have kind of a foul odor, there's a good chance that it's meconium, which is the baby's first bowel movement. So the baby had a bowel movement in utero, and it's just kind of floating around within the amniotic fluid. For physical exams, assess major body systems as needed, emphasis on the chief complaint. If the patient's in labor, focus on contractions and possibility of delivery. And if you suspect that delivery is imminent, check for crowning. So you're going to actually visualize the vaginal opening to see if you see a head. You see a head there. Delivery is imminent. Baby's coming. Vital signs, get them, monitor them. Be especially alert for tachycardia and hypo or hypertension. Hypertension, even mild, may indicate serious problems like preeclampsia or potentially eclampsia. Repeat your primary assessment, obtain another set of vitals, check intervention and treatment. In most cases, childbirth is a natural process, does not require your assistance. But when childbirth is complicated by trauma, any interventions that you provide the patient help the fetus. Again, like I've said before, any life-saving measures that you do for mom are going to positively benefit the baby. Communication and documentation provide an update on the status of the woman and the newborn baby after delivery. So you are going to call the hospital. You are going to tell them that you are en route to their facility with a 10-minute ETA. You have a mom who is, 41 weeks pregnant and having contractions quite frequently. Delivery is imminent. And then once the baby is born, make sure you call the hospital back and you let them know that you now have 2 patients. You don't want to be surprising them with a baby. So just give them a heads up and let them know that the baby has been delivered. For a pregnant patient with a complaint unrelated to childbirth, make sure you include the pregnancy status in your radio report. You don't want to show up with a, a allergic reaction and surprise them with the fact that they are very pregnant, or say you've got someone who appears to be having a stroke. don't surprise them with the fact that they're, maybe 32 weeks pregnant. That patient is going to go to a different area. They're not going to go to the ER. They're actually going to go up to L&D, and they'll get all the same care, but they'll also be monitoring the baby at that point. So it's in the patient's best interest that you make sure that you give all the appropriate information so the hospital can be prepared and get them to the correct area. If delivery occurs in the field, you'll have 2 patient care reports to complete and twice the amount of documentation. So let's talk about labor. So you have 3 stages of labor. You have the first stage, which is the dilation of the cervix. The second stage, which is delivery of the baby. And then the third stage, which is delivery of the placenta. So first stage begins with the onset of contractions and ends when the cervix is fully dilated, usually the longest stage lasting an average of 16 hours. During my first pregnancy, I was advised that that is not correct, and the average for first pregnancy, first stage of labor, is closer to the 23-hour mark. So it can be significantly longer. Frequency and intensity of contractions will increase during this time. Labor is generally longer in primigravida than in multigravida. So for the first pregnancy, it's going to be a lot longer, usually, than with second, third, fourth, fifth, however many pregnancies. And with each one, it generally gets a little bit quicker. So it's kind of important to find out, if this was not her first baby, how long the last baby took. What happened with the last baby, because there's a good chance it's going to be happening faster. A woman may experience preterm or false labor or Braxton Hicks contractions, where they may think they're in labor, but it's not actual labor. It's just the body kind of practicing and getting ready for delivery. So women experience premature rupture of the amniotic sac. This can be detrimental to the baby. Anytime you are opening the baby's nice sealed, contained environment, you're opening them to bacteria, and they're more susceptible to having infection. Anytime you have a premature rupture, there's a good chance that mom is going to be put on bed rest, monitored in hospital, possibly put on antibiotics, to try to help preserve the baby and keep the baby cooking for as long as possible before they'll allow labor and delivery to actually move forward. Here you've got just some differences between false labor and true labor. So second stage. Second stage begins when the fetus starts to encounter the birth canal, and it ends when the newborn is born. Uterine contractions are usually closer together and last longer, and the perineum will bulge significantly, and the top of the fetus's head will appear at the vaginal opening, which is called crowning. In the field, there's a slight difference in this because we are not going to be doing exams. So we're not going to be inserting our fingers to determine whether the cervix is completely dilated or not. So in the field, the difference here is that the first stage starts with the first contraction and ends when you can see the head. The second stage starts when you can see the head and ends with the delivery of the baby. So it's the difference with the field, and I believe you have a test question that specifically talks about that. Let's see here. So the third stage begins with the birth of the newborn and ends with the delivery of the placenta. The placenta must completely separate from the uterine wall, and it can take up to 30 minutes. You are not going to be pulling on cords. You are not going to do anything to encourage the thing to come out. You will let it do it on its own. Mom may feel the need to push again. That's fine. She can push it out, but you are not going to be pulling it out. You can cause some serious problems. If you pull on it and part of it stays attached, You just bought that poor woman an additional surgery to have that piece of placenta removed, so she doesn't develop a life-threatening infection. Do not pull on it. Consider delivery so when you're preparing for delivery, consider delivery at the scene when delivery is imminent. So if it's going to happen within the next couple minutes, then you need to deliver on scene. If you've got some time, then go to the hospital. They're like, why do it in their house if you can get them to the hospital? Another circumstance when it would be beneficial to prepare to deliver on scene is a natural disaster, inclement weather, or other environmental factor that makes it impossible to reach the hospital. For instance, here in Tucson, Arizona, we get monsoon flooding. If the roads to the hospital are completely flooded and not passable, then that would be a circumstance to prepare for delivery at the scene. It would be a good idea to have someone standing or waiting at the wash so they can radio to you to let you know that the wash is now safe to cross. So that way you're not delivering at home when it's not necessary to do so. So even here in Tucson, we don't have blizzards or tornadoes, but there are some circumstances, environmental factors that can make it necessary to deliver at home. To determine if delivery is imminent, ask the patient, how long have you been pregnant? So how far along are you? When are you due? Is this your first baby? Are you having contractions? If you are, how far apart are they and how long do they last? Again, they will get more severe and they will get closer together and they will last longer in duration the closer you get to delivery. So if they're happening one right on top of another and she cannot speak through them, then there's a good chance that you're pretty darn close to delivery. Have you had any spotting or bleeding? Did your water break? Do you feel like you need to have a bowel movement? That feeling that you need to have bowel movement is more likely than not the fetus's actual head pressing on the rectum, not fecal matter. Do you feel the need to push? If the answer is yes to any of those, stay and play. Get that baby, or get an environment set up to deliver that baby. To determine potential complications, ask, were any of your previous deliveries by C-section? Have you had problems in this or any previous pregnancy? Do you use drugs, drink alcohol, take any medications? Is there a chance of multiples? You don't want to find out there's twins when you think you're done and you still have another baby to deliver. Does your physician expect any complications? So again, placenta previa, that's a big one. It's a huge complication. That cannot be delivered at home. That has to have a C-section. You cannot deliver that baby at home. Prepare for delivery if the patient says she has to move her bowels or feels the need to push. Visually inspect the vagina to check for crowning. Once labor has begun, it cannot be slowed or stopped. Never attempt to hold the patient's legs together. Don't let her go to the bathroom. She may have to go to the bathroom, but you don't want to risk her pushing a baby out into the toilet. So be professional, use exercise tact, and do the best you can to just help her understand that if she poops, then that's fine. That means that she's doing it right. So kind of expect that. It's very common and a lot of times happens during delivery. Again, just try to be tactful and don't make her feel uncomfortable. Remember that if you deliver on the scene, you're only assisting the woman in the delivery. You're not actually doing much. You're just helping her. Your emergency vehicle should always be equipped with sterile OB kit. So you should have all of the stuff that you need for a sterile delivery. For patient position, preserve the patient's privacy. Place the patient in a firm surface that's padded with blankets, sheets, and towels. Support the head, neck, and upper back. Have her keep her legs and hips flexed with her feet flat and knees spread apart. Let her deliver how she wants to deliver. If she wants to stand on her head and have a baby that way, maybe suggest something else. But if she wants to squat and have a baby, then let her squat and have a baby. If she wants to be on her hands and knees to have a baby, let her be on her hands and knees to have her baby. Her body is going to be telling her what to do. Some positions are going to be extremely painful, where other positions may give her some relief. Let her do what she needs to do to help facilitate delivery. Preparing the delivery field, place towels or sheets on the floor around the area. Again, it's going to be messy. It's going to be very messy. So be prepared for that. Open the OB kit carefully. Use an aseptic technique. So in class, your instructor or myself will show you how to do that, to open the sterile kit and keep everything sterile for the baby. Use the sterile sheets and drapes from the OB kit to make a sterile delivery field. Again, if mom wants to deliver in this position, this is kind of a general idea of how you can respect her modesty, keep her covered, and also kind of have a clean delivery field. Your partner should be at the patient's head to comfort, soothe, and reassure. Continually check for crowning. Some patients will experience precipitous labor and birth. Position yourself so that you can see the perineal area at all times, and time contractions. When I say the patient can have precipitous labor and birth, the baby could shoot out. So we suggest that you provide gentle back pressure, is what we call it. So you'll see the baby's head coming out of the vaginal opening. You can just provide gentle back pressure. You're not pushing on the baby. You're just preventing the baby from shooting out like a cannon. You want to provide that gentle pressure. One, it's going to protect the baby, but also it's going to protect mom. When there is a precipitous delivery and the baby kind of shoots out, she's a lot more likely to have some serious tearing of her tissues because the body can't handle that quick opening of her tissues. She needs to have that little bit of a gradual opening to not tear. So do mom a big favor and have that gentle pressure so you can help save mom with her recovery. You deliver the head, so observe the head as it exits the vagina. Support the head with your gloved hand as it rotates. Obviously, don't poke your fingers in their eyes. That should go without saying, but be mindful where you're putting your fingers so you don't do it on accident. If there is an unruptured amniotic sac, it'll bulge out of the vagina. It just looks like a giant water balloon. If you have that, you can puncture the sac with a clamp or you can tear it. So you kind of like the snapping motion, you can kind of grab it and like twist it and it should rupture. Before you do that, get a bucket because you're going to have that fluid rushing out at you. And if you don't have anywhere to put it, it's just going to go all over you. So try to have something to collect it and contain it before you rupture it. If you don't, it could deliver its, all intact, and that would be great. It happens on occasion, but it could also suffocate the baby. So why would you take that chance? Just rupture it, drain the fluid out, remove it from the infant's face, and then continue with delivery. Clear the newborn's mouth and nose immediately. Your next step, as soon as the head is out, you need to reach in with your gloved hand and trace the infant's neck with your finger. So you'll trace your finger around the infant's neck and you're feeling for an umbilical cord. If you feel an umbilical cord in there, you're going to grab it and gently try to pull it over the baby's head. Do one attempt. If you can pull it over the baby's head, then great, you can continue with delivery. If it's too tight and it won't go over the baby's head, you're going to have to clamp it on two sides and then cut it in the middle. Be mindful that there's an artery and a vein in there. So if you don't clamp it and you just cut it, both mom and baby are going to start bleeding. So make sure you're cutting it. It's basically kind of like a tourniquet on either side, and then you're cutting in between the two. Once you cut it, you can unwrap it around the baby's neck, and then the baby can be delivered. Now, remember that the other end of that umbilical cord is attached to the inside of mom's uterus. So if it is wrapped around the baby's neck, the further the baby comes out, the tighter it's going to be. You absolutely must check for that umbilical cord and cut it if necessary so you don't strangulate the baby. Let's see. So delivering the body. Once the head is born, the body usually delivers pretty easily. So the baby the rest of the baby comes out. Support the head and the upper body as the shoulders deliver. Don't pull on the baby, just kind of support it. And again, keep it from shooting out. The newborn will be slippery and covered with vernix. It's just it kind of looks like cheese kind of on the baby. It's expected. It's not a big deal, but they can be pretty slippery. So make sure you have a good hold on them. You don't want to drop the baby. And it's a good idea to have the baby close to the ground so that if you do accidentally drop the baby, you're not going to hurt the baby. So be mindful of that also. If the mother is able and willing, place the newborn on her abdomen so skin-to-skin contact can begin immediately. You can, after the baby's on mom's belly, you can dry them off, cover them with a towel, and you can place the newborn on their side with the head slightly lower than the rest of the body to help kind of drain out that excess amniotic fluid. Now, think about our environment. So here in Tucson, I mean, my air conditioning is blowing right now, and I think I have it set at like 76. So my house is somewhere in the area of 76 degrees. What's your body temperature? Like 98, 99 degrees, 97, 98, 99, somewhere in that range. So that baby has lived literally its entire life in 90 something, 99 degrees, 100% humidity, and they've never been outside of that environment ever. So now you're going to expose them to 72, 76 degrees of freezing cold air. They are going to lose, they have really poor thermal regulation as it is. And then you're taking them to this drastically different temperature. They're going to lose their body heat very, very fast. So by putting naked baby on mom's bare belly and then covering them with a blanket, it helps the baby conserve some of that, conserve body heat. You don't want that baby to lose too much of it because it can create some problems for the baby. So you will clamp and cut the cord. And during your hands-on portion of this, we'll show you how to do that. But you want to clamp it relatively close to the baby's body. So maybe 2 inches or so. I think your book says up to 3 inches. And then also remember you have to clamp the other side and then you cut in between the two. Get your APGAR score at 1 minute. And we'll cover the APGAR score later. It's basically a Glasgow Coma scale, kind of, but it's the equivalent for a brand new newborn baby. After the baby's born, and you go through the process of drying them off, you've got skin to skin happening, you've got your APGAR score, then mom's about ready to start delivering the placenta. So be mindful that that's coming next. The placenta delivers itself usually within a few minutes. It can take a little bit of time. Again, you're never going to pull on it. You're going to let it do its thing. You're going to let mom push it out if she feels like she needs to. You can help, so bleeding. I talked about it a little bit before, but if mom is hemorrhaging, so mom has had some significant bleeding after the delivery of the baby, you can do what's called a fundal massage. So again, you use your fists in like a kneading motion, and you're going to kind of like start on the sides and ball up the uterus. So you're pushing down with pretty good force and kneading the mom's belly back into like a tight ball to try to help put pressure on the uterus to help control that bleeding. Now, if mom is willing to breastfeed, that is another good way to help control bleeding. When mom starts to breastfeed, mom starts to produce hormones, which will cause her uterus to contract, again, which will help control bleeding. Record the time of birth in your patient care report following our emergency situations. So if you've gone 30 minutes and you still don't have a placenta, you can consider that an emergency. If there's more than 500 milliliters of bleeding before delivery of the placenta, again, that can be a big deal. You need to get her to the hospital. And then if there's significant bleeding after the delivery of the placenta, mom can hemorrhage, mom can bleed out and die. So you really need to control that bleeding. And if you can't control it, you need to get her loaded up to get her to the hospital so they can do, possibly a surgery to get that bleeding controlled. Neonatal assessment and resuscitation. So now that the baby's born, now you have a whole new patient that you have to deal with. So follow your standard precautions. You should still have gloves on. It may be a good idea to switch out your gloves so you have nice clean gloves instead of nasty ones. Never handle an infant without gloves on. Always have gloves on. Newborns will usually begin breathing spontaneously within 15 to 30 seconds after birth. Their heart rate's going to be quite high, 120 or higher. If you don't observe these responses, gently tap or flick on the soles of the feet or rub the back. Drying them. So you've got a towel or a receiving blanket and you're drying them off. That's really good tactile stimulation, and that's going to help kind of jumpstart their system. You have to remember that these infants have never had to do anything on their own. They've never had to breathe on their own. They don't even have to like circulate their own blood. Like mom kind of does everything for them. So the moment they're born and that umbilical cord is clamped, they are now completely on their own. And it takes a little bit of time to kind of jumpstart that system. Stimulating them by drying them off, rubbing them with the towel gently, of course, will help jumpstart that system and get them doing their, working their own system on their own. Just about every neonate is going to need some form of stimulation. So position the airway, drying, warming, suctioning, tactile stimulation, those are all things that are going to help stimulate that baby to breathe and to kind of start functioning on their own. This is just kind of a table 33-2. It's in your book. You can look at it. It gives you an idea of what you can do to help resuscitate a newborn who's not breathing. Just a bunch of different ideas, different things that you can try. Position the newborn on their back with their head down and the neck slightly extended. What you're doing is you're opening that airway. So if you think of an adult and you think of head tilt, chin lift, you're putting the head back. So what you're doing with this infant is you're kind of turning them not totally upside down with head down and their head slightly extended, then it's opening up their airway. If necessary, suction the mouth and the nose. You always want to suction their mouth first, then their nose, because they are mouth breathers. So, as soon as, suction their mouth and then their nose. So you're suctioning out all the gunk from their mouth so that when they take a breath, they're not getting a bunch of gunk. If you stimulate them to breathe by suctioning their nose, they're going to take a deep breath and they could get gunk down into their lungs, which you don't want. Observe the newborn for spontaneous respirations, skin color, and movement of extremities. Those are the steps for the APGAR score. Evaluate the heart rate at the base of the umbilical cord or at the brachial artery, or listening to the newborn's chest with a stethoscope. If you have a hard time feeling for a pulse, you can always pull out your stethoscope and listen for a pulse. So if the heart rate is more than 100 beats, then that's a good sign and keep going. If it's between 60 and 100, you're going to need to start ventilation with the BVM, with room air, and kind of go from there. If the heart rate is less than 60, you're going to need to start ventilation with O2, and then reassess. And if you don't see improvement, you're going to have to start CPR. You definitely need to get ALS involved. This is a big deal. So you want greater than 100. That's kind of your goal. If it's not 100, the closest to 100 as you can get. If you're under 60, you're in trouble. You need to get someone there on their way because you don't have a lot of time if things go bad. So you'd rather have someone on their way than be behind the game. If chest compressions are required, use the hand encircling technique or for a two-person resuscitation. So in your CPR class, there was something that kind of resembled this. So you're like holding the infant on, with their back and then using your thumbs to provide the compressions. That's what they mean by that. Perform BVM ventilations during a pause after every third compression using a ratio of 3 to 1. 3 to 1 is a ratio reserved only for neonates. So literally they just came out of mom and they need some help with that kickstart. So 3 to 1. 3 compressions, 1 ventilation. 3 compressions, 1 ventilation. And then you can reassess, every, I think it's 90 seconds. If you see meconium in the amniotic fluid and the newborn is not breathing adequately, quickly suction the newborn's mouth and then the nose before providing rescue ventilations. It's just more gunk that they could have down in their lungs. So they may just need more suctioning than the average newborn. So here's that APGAR score that I've been talking about. So the standard scoring system used to assess the status of a newborn. It assigns a number value to 5 areas: appearance, pulse, grimace or irritability, activity or muscle tone, and respirations. This one's easier than GCS because it's simpler than the GCS. The total of the 5 numbers is the APGAR score, and you calculate it at 1 minute and 5 minutes after birth. So here you have it. So basically, if that category is good, then they get a 2. If the area is okay, then you get a 1. And if the area is bad, then you get a 0. It's very simple. So appearance, the entire baby is pink. That's good. That's what you want. You get a 2. If the body is pink, but the hands and feet are blue, then that's not great. You get a 1. If the whole baby's blue, they get a 0. So pulse, more than 100, that's good. They get a 2. Less than 100, that's not as good. It's a 1. And if they don't have a pulse, then they get a 0. Grimace and irritability. So the newborn cries and tries to move away from you bugging them. So you're trying to tickle them and they're pulling away from you and they're getting upset. Then they get a 2. That's a good response. If they make a weak cry in a response to stimulus, then that's not as great and they get a 1. If they don't cry at all and they don't react to stimulus, then that's really bad and they get a 0. Activity or muscle tone. So a newborn resists attempts to straighten hips and knees. So think of it as like when you're sitting watching a movie and you've got your legs all curled up underneath you. After 2 hours and you go to get up and move, everything's kind of stiff and it doesn't feel so great when you start opening it up. Now, they've been tight for a lot longer than a couple hours. So when you try to pull their legs straight, they're naturally going to want to curl back up because that's their most comfortable position. If they make a weak attempt to resist straightening, they get a 1. And if they completely do not, like they're limp, they're not resisting you at all, then they get a 0. Respiration, if they're fast, they get a 2. If they're slow, they get a 1. And if they're not there, they get a 0. Like I said, APGAR score is significantly more simple than the Glasgow Coma Scale. So assessing a newborn, calculate the APGAR score. Stimulations should result in an immediate increase in respirations. If the newborn is breathing well, assess the pulse, assess oxygenation via pulse oximetry, and observe for central cyanosis. Request a second unit if the newborn is in distress and will require resuscitation. In situations where assisted ventilation is required, use a newborn BVM. Newborn BVMs are significantly smaller, so it's not just the size of the mask, it's the size of the bag as well. So they're significantly smaller, and they have what's called a pop-off valve. So it makes it so it's impossible to overinflate their lungs. They are very tiny, their lungs are very tiny, and they're very delicate. So if you force too much air in, you can cause some serious damage or trauma to their lungs. So you want to make sure that you have an appropriate size bag. Now, I'm sure as you learned in your CPR course, you can use an adult size mask on an infant. You just flip it over. So instead of, the round part that goes over the chin, it would go over the infant's forehead. But you still need to use an infant neonate size bag, the smallest one. If the newborn does not begin breathing on their own or does not have an adequate heart rate, continue CPR and drive fast. So a couple different complications we're going to go over here. So breech delivery. Breech delivery means butt's coming first. Most infants are born head first, but on occasion they get mixed up and they come out butt first. It's called breech presentation. Now, this is not ideal, but it can be done. There's some additional things that you need to worry about. So when mom delivers the baby, the butt's going to come first, legs are going to be caught up, and so it's going to create a more difficult delivery, and the baby's more likely to get stuck. So again, this is not ideal. If you can avoid delivering this in the field, you don't want to. You want to have this delivered in the hospital. Additionally, if the body and the legs can come out, then mom's cervix has a good chance of actually starting to close up before the head comes out. So to prevent that from happening, or to prevent the baby from getting stuck with their head inside mom's body, we can do, you make a bridge with your fingers. So you'll actually put your palm on their chest and use your first two fingers and put it on their chin and kind of help support their airway and help keep their chin to their sternum open. You're creating a bridge there to help keep mom's cervix from closing over the baby's head, so the baby doesn't get stuck. They generally take longer. You often have time to transport the hospital. If the butt has already passed through the vagina, delivery's begun, you can't go back from that. You have to just keep going forward. Preparing for the delivery is the same. You allow the butt to come out, the legs come out, spontaneously supporting them with your hand. The head is almost always face down and should be allowed to deliver spontaneously. You make a V with your gloved fingers and position them into the vagina to keep the walls from compressing on the fetus's airway. So like I said, and I don't know if you can see my picture here, but you're putting your fingers on the baby's chin and you're putting the palm of your hand on their chest. So you're creating a bridge to help keep mom's body from closing around the baby's throat. So here's another one. So on rare occasions, the presenting part of the fetus is a single arm, leg, or foot. This is called limb presentation. Now, how this happens is kind of interesting, I guess. So when mom's water breaks, it creates a vacuum. So all of that water comes out. Unfortunately, it also pulls whatever's closest out with it. So that's how you end up with a foot sticking out. It's not like baby kicked too hard and then whoop, there it went. It's more or less that vacuum pulled it out. Now, This is not something that you can deliver in the field. They may be able to deliver it in the hospital if it's a foot that's out, but if it's an arm out, this is an emergency surgery. There's nothing that can be done. They have to have a C-section to get this baby out. And you need to move fast because it can be life-threatening. Transport immediately. If the limb is protruding, cover it with a dry towel. Never push on it, never pull on it. Just let it be, and just get them to the hospital as quickly as you can. So prolapse of the umbilical cord must be treated in the hospital. This is a life-threatening emergency. This is a very big deal. And as long as that cord is out and the baby's head is pushing on the cord, that baby is going without oxygen. So this is life-threatening for the baby. The umbilical cord comes out of the vagina before the baby comes out, and then the head is pushing down on the cervix because the uterus is contracting and trying to force the baby out. So the baby's head is actually putting pressure on the umbilical cord and cutting off its own circulation. It's basically like a tourniquet. So you're not going to push the cord back into the vagina. You're not going to pull on it. You are going to reach your hand in and try to push the baby's head away from the cord. You're trying to help keep the pressure, off of the cord with your gloved hand. You're going to drive fast. You're going to get this patient to the hospital. You're going to advise on your telemetry that you have a cord presentation or a prolapsed umbilical cord. And likely you are going to have your hand in there pushing the baby's head away from the umbilical cord. You may get to trade off with someone in the hospital. They may take over for you, or you may stay there and follow the woman all the way up to the OR where she's going to get a C-section to try to save that baby's life. Drive fast, get her to the hospital, make sure that you relay that information in your telemetry so that mom and baby have the best chance of survival. So spina bifida, this is another, this is kind of a rare complication. It's a developmental defect in which a portion of the spinal cord or the meninges may protrude outside of the vertebrae. If you have this, and I think there's a picture of it, maybe not. So if you have this, you have this like bulging mass sticking out of the baby's back. You're going to cover that open area with moist, sterile dressing and maintain body temperature because, again, they're already having a hard time with thermal management, and then you go and you put moist dressing on them, it's going to make them even harder to maintain that body temperature. Multiple gestation. So twins, they happen once in every 30 births. Twins are smaller than single fetuses, and delivery is typically not difficult. After 10 minutes or so, after the first baby is born, then contractions start again, and the birth process repeats itself, and then you have two babies. The procedure is the same for a single fetus as it is for multiples. Record the time of birth for each twin separately. Twins may be so small that they look premature. They may have breathing problems. They may have difficulty. You just treat them as they present themselves. With premature birth, so any newborn who delivers before 8 months or 36 weeks or weighs less than 5 pounds is considered premature. A premature newborn is smaller and thinner, and the head is proportionately larger. Again, they're also more likely to have respiratory problems. The respiratory system, you don't need it when you're in utero, so it's one of the last things to develop. So if you're born early, there's a good chance that it may not be developed all the way. So they're more likely to have some serious respiratory problems. So kind of be prepared for that, especially if you have an idea that they are premature. So here you have a picture of a term baby compared to a premature baby. Size-wise, there's not a huge difference, but weight-wise, there is a big difference. The full-term baby has had a good chance to plump up before delivery. Generally, premature babies require intervention in order to survive. So definitely, be prepared for that and be on it. Get going with resuscitation as soon as you realize that it needs to be done. Post-term pregnancies. So these are pregnancies that last longer than 42 weeks. The fetus can be larger, sometimes weighing more than 10 pounds, and it can lead to problems with the woman and the fetus, including a more difficult labor and delivery. Additionally, and the biggest concern with post-term deliveries is that the placenta starts to die at around 40 weeks. So the placenta stops doing its job. And if you go beyond 42 weeks, statistically, 73% of births, I'm sorry, after 42 weeks, the fetus is 73% more likely to be born dead or to be stillborn after 42 weeks. So most obstetricians will not allow a woman to go beyond 42 weeks because the chance of survival is quite a bit, like significantly less once you pass that 42 week mark. More problems with post-term, increased chance of injury to the fetus, an increased likelihood of C-section, the woman's at risk for perineal tears and infection, and post-term newborns have an increased risk of meconium aspiration, infection, and being stillborn. Fetal demise. So this is when the baby dies in utero. So onset of labor may be premature, but labor will progress normally in most cases. If there was an infection that caused the baby to die, there's going to be a foul odor. Once the baby comes out, don't attempt to resuscitate an obviously dead baby. So if they have already started to decompose, you're not going to be doing any sort of resuscitation. So if it's obvious that they're dead, then no resuscitation. If you have to deliver and you don't have sterile supplies because you didn't do a good truck check, you should always have eye protection and gloves and a mask with you. So that shouldn't change. Carry out the delivery as if sterile supplies were available. Use freshly laundered sheets and towels. Wipe the inside of the newborn's mouth with your finger instead of using suction because you don't have sterile suction. So you can kind of scoop out that amniotic fluid. You can not cut the cord at all. So just keep the placenta and the baby at about the same level. If you have the placenta slightly higher than the infant, gravity can kind of drain the blood out of whichever is higher into whichever is lower. So if the placenta is higher than the baby, it's not as big of a deal because you're just draining fluid out of placenta that doesn't need it into the baby that does need it. But if you have the baby higher than the placenta, then you could be draining the blood from the baby into the placenta, which would be detrimental. So you just need to be careful to keep them at the same level, or if anything, the placenta is slightly higher than the baby. As soon as the placenta delivers, wrap it in a clean towel and transport. Keep the placenta and the newborn at the same level. If anything, keep the placenta higher and keep the baby warm. If bleeding continues after delivery of the placenta, continue to massage the uterus. Check your technique and hand placement if bleeding continues. Cover the cover the vagina with a sterile pad because bleeding is expected. So you need to collect the blood. And administer oxygen, monitor vitals, and transport the patient immediately. Postpartum patients are at an increased risk of an embolism. Most commonly, a pulmonary embolism results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation. So remember, we talked about it earlier. The mom has an increased blood volume to accommodate for bleeding. So the body produces more blood to be prepared for bleeding. It also creates a higher or an increased clotting factor to help with bleeding, which is expected with childbirth. So unfortunately, mom has an increased clotting factor, which means that she can develop clots anywhere. And if a clot ends up developing and then working its way through the circulatory system, you can end up with blood clots anywhere. So if it lands on the heart, you have cardiovascular problems. You have, maybe an infarct, or it ends up in the lung and you end up with an embolism, or it ends up in the brain and you end up with an ischemic stroke. These are all complications that happen as a result of that increased clotting factor. Consider a pulmonary embolism when a woman complains of sudden difficulty breathing or shortness of breath following delivery. So for the review, the first stage of labor ends when what? So remember, this is different for in the field than clinical. So we are going to call it as A, the presenting part of the baby is visible, because again, we can't check that her cervix is fully dilated because we're not supposed to be doing exams that way. So here you have the rationale that the first stage of labor begins with the onset of contractions, ends when the cervix is fully dilated. However, since cervical dilation cannot be assessed in the field, the first stage of labor is considered over when the presenting part of the baby is visible at vaginal opening, which is called crowning. So I wanted to make sure that you guys were aware of that. That's why I pointed it out within the lecture. 23-year-old woman who is 24 pregnant with her first baby complains of edema to her hands, a headache, and visual disturbances. When you assess her vital signs, you note that her blood pressure is high. She's most likely experiencing what? So here you have a whole lot of things that lead you to believe that she has eclampsia. So eclampsia, again, is pregnancy-induced hypertension. Once it progresses into seizures, that's when you have full-blown. You're transporting a woman who is 8 months pregnant to prevent supine hypotensive syndrome. You should transport this patient how? So again, on her side, you absolutely have to check for it. You are going to check the position of the umbilical cord. So that way you can push baby further. When it's wrapped around the baby's neck, it's called a nuchal cord. So if you see that, that's what they're talking about with a nuchal cord. On delivery of the baby's head, you note that pull the cord over the baby's head, releasing it from around its neck. You're going to try once. It's not stretchy. If it doesn't go the first time, it's not going to go a second or third time. So try one attempt to slip the cord over the baby's head. And if it doesn't go over, then you're going to clamp it in two spaces and cut it down. So the nation is based on what? So you have 1 minute APGAR score, gestational age, newborn's response to oxygen, or respiratory effort, heart rate, and color. Respiratory effort, heart rate, and color is going to be all of the things that matter when it comes to resuscitation. APGAR score is not used to determine resuscitation, and the first score is not even assessed until 1 minute. So respiratory effort, heart rate, and color are all things that you can see right away. You don't have to wait a minute to determine whether or not the baby should be resuscitated. 1 minute APGAR score of a newborn reveals that the baby has a heart rate of 90. So remember, heart rate greater than 100 or less than 100. So this is less than 100, so they get a 1. Pink body, but blue hands. So again, not ideal, but also not horrible. So they get a 1. Rapid respirations. So rapid is good, slow is bad, absent is really, or slow is okay, absent is really bad. So they're rapid, so they get a 2. Baby cries when the soles of its feet are flicked. So that's good. That's a good response. So they get a 2. Resists attempts to straighten its legs. So again, that's good. They get a 2. So that 1 minute APGAR score, you have 5, 6, 7, 8. You should have an 8 for this particular APGAR score. And that is correct. 8. C. Most effective way to prevent cardiopulmonary arrest in a newborn is to what? Obviously, we're not going to be rapidly increasing body temperature. That would be dangerous. We're not going to allow them to be hypothermic. We definitely are going to ensure oxygenation and ventilation. And we are definitely going to be doing CPR if the heart rate, no, we're not going to be doing CPR if the heart rate is less than 100. We're going to be doing CPR if the heart rate is less than 60 and does not respond to oxygenation. So with that being said, your correct answer here is going to be C, ensure adequate oxygenation and ventilation. So while assisting a woman in labor, you visualize her vaginal area and see an arm protruding from her vagina. She tells you that she has the need to push. What do you do? First of all, you can't deliver this in the field. There is absolutely nothing that can be done to deliver this baby in the field. So you are definitely not going to encourage her to push. You're not going to be pushing your hand up into the vagina to try to flip the baby around. And you're not going to instruct the woman to continue pushing. This is something that just, you have to just cover the baby, keep the baby safe, whatever part is coming out, with a sterile towel, and get them to the hospital as quickly as possible. So a newborn is considered to be term if it's born after how many weeks and before how many weeks. So remember, after 36 weeks. So, or up to 36 weeks is preterm. So 37 weeks is good. And then before 42 weeks. So the answer here is B, after 37 and before 42 weeks. So if you have questions on any of this, you're welcome to either email myself or your instructor. So for some further, clarification. And then in class, we will do a hands-on so you can kind of get an idea, and we can show you some videos to show you kind of what to expect and how to manage some of these more complicated deliveries. So again, if you have any questions, just go ahead and contact either myself or your instructor.